It is my pleasure now to introduce our first presenter and moderator for today's event, Ross Manson. Ross is a principal with the Healthcare Consulting Industry Group at Eide Bailly, a regional public accounting and business advisory firm headquartered here in Fargo. Eide Bailly is one of the top 25 CPA firms in the nation and has been serving healthcare clients since its inception in 1917. In his role at Eide Bailly, Ross works with hospital management teams on financial feasibility studies, strategic planning, operational assessments, process improvements, and productivity measurements. Ross is president of the North Dakota chapter of the American College of Healthcare Executives and a member of the National Rural Health Association. Please welcome Ross Manson.
Good morning, everyone. What a great turnout here it is today. Well, my first question is, has anybody read the 2,700-page bill? Okay, well, security will have to remove this one guy over here. But we did give you an idea of how big the bill is. Right there is 2,700 pages. So I'm going to take the first 500, and then the rest of the panel is going to take the last 2,200 pages. Healthcare reform, though. It's a very hot, contested political item out there, and it's got lots of different components that are going to impact employers and individuals going forward. So the focus of my presentation today is going to give you a lot of specifics about the bill. First of all, though, I'm going to start with some healthcare industry trends and some implications as to why did healthcare become such a hotly contested political item. Second, I'm going to focus on the bill's impact on employers, some specifics on the bill's impact on individuals, and then also just going to wrap it up with some future implications. So how did we get to this point? If you remember in the 2008 elections, there was a lot of conjecture back and forth among the presidential candidates about the number of uninsured in our country. And that was really one of the precipituses that was driving this bill. Right now there's about approximately 54 million people that are uninsured in the country. And if you take a look at it on a state-by-state basis, North Dakota has about 11% of the population is uninsured, and Minnesota has about 8.5%. North Dakota and Minnesota actually do a very good job in regards to the number of uninsured. Most other states in the country are somewhere between about 15 to 17% of their population is uninsured. So this bill has less of an impact for the number of people in our population that are uninsured. The second component to why healthcare became such a political item is the dollars that we spend from a national perspective. Last year we spent about $2.5 trillion, the same amount that we spent on housing, and that is projected to increase to $3.1 trillion by 2012. Here it is as a percentage of our United States healthcare expenditures as a percentage of GDP. And you can see it dates back to 1960 when we spent 5%. And just in case anybody doesn't know, GDP stands for gross domestic product. So that's an accumulation of all of our goods and services. This growth rate is fiscally unsustainable for not only our government, but for other businesses as well. The more that we spend on healthcare, while it's good for us that work in healthcare, that means that less dollars are being able to be spent on other businesses and other goods and services out there. So there has to be some trends, there has to be some different components, some cost containment that we're looking at, and this bill tries to take a step in that direction. So you might ask, how do we compare against other countries? Well, this slide is a little bit, isn't quite, the previous slide had 2009 data. This slide is based on 2007, which was the most recent year that I could get. This does a comparison of other countries that we would compare ourselves to as we take a look at our total expenditures as a percentage of GDP. And you can see that we far outpace other countries as the amount that they spend. And so the United States, many opponents to the United States healthcare system talk about the amount of dollars that we spend on a per capita basis and how it doesn't equate to the same kind of outcomes that other countries get. And a lot of people talk about the World Health Organization when they do their rankings of healthcare systems across the country. And I think the last one had the United States ranked 32nd in the world. Well, there's a number, if you actually go into the survey and the calculations that they look at that, there's a number of different components that drive the United States down. And the two biggest areas that drive and impact the United States are very subjective criteria in that analysis, and one is that they look at fairness and the dollars that you spend from an out-of-pocket perspective. And fairness really comes down to ability of people to, the amount of people that have insurance or have care accessible to them. And the United States has been negatively impacted in that category because of our number of uninsured. But when you actually break it down and you look at the clinical outcomes, the United States is number one across the board in outcomes and survival rates and a number of different comparisons. Another analysis that I can give to you is that they look at infant mortality rates. And if you take a look at infant mortality rates, you'll probably have heard, if anybody's seen the movie Sickle by Michael Moore. Michael Moore talks about that Cuba has a lower infant mortality rate than the United States. Well, that's true if you look at just the numbers. But as you dig into the numbers, there are two main reasons that drive that. One is, first of all, Cuba has almost, they're either the top or the second largest or highest country that has the highest abortion rates in the world. And secondly, the United States also has the ability, the technology, the physicians, the specialties to take premature babies to term and make sure that some of those babies can live on. But we do experience losses in that category, so that impacts our infant mortality rates. And I could almost guarantee that we'd have 100% of mothers in here that would say that they'd rather deliver their baby here in the United States than go to Cuba and do that. So take that with a grain of salt as you take a look at that when you hear those World Health Organization rankings. The last component to talk about from the healthcare perspective is on the cost side is taking a look at the average premium increases that we've seen from 1999 from a health insurance perspective to 2009. And you can see that it's gone from $5,790 to $13,375. And you can see that that cost has been shared both by the employer and the employee. The correlating factor here as you take a look at this is that wages during that same time period have grown from on average, about 40 to 45%. So these healthcare insurance premium costs are cutting into people's disposable income at a greater rate than we've seen. Now I'm going to do my best Joe Friday imitation and just get to the facts. Small employers, before I get into the facts, I'm going to talk about the bill, or how the bill came to fruition. So the Patient Protection and Affordable Care Act was passed by the Senate on December 24th of 2009. If you remember, prior to that, the House actually passed their version in November. So there was two versions of healthcare reform out there that were both being contested. Then what happened is with the passing of Senator Ted Kennedy in Massachusetts in January, you had Republican Senator Scott Brown that was elected in the state of Massachusetts, taking away the 60 Senate filibuster-proof numbers that the Democrats needed when they looked at health care reform. So then on March 21st of this year, 2010, the House passed the Senate's version of the bill. And along with that, they also passed the Health Care and Education Reconciliation Act of 2010. There's some reconciling items that the House wanted to include in health care reform. And then that was passed by the Senate on March 25th, and then the President signed it into law. So, some facts of the bill from an employer's perspective. We're going to first focus in on employers. Starting in this year, in 2010, there's a small employer health insurance credit that small employers will have access to this year. You have three requirements that you have to meet from that small employer tax credit side. Is that you have to be less than 25 full-time employees, and keep in mind here, full-time employees, one of the key designations, because in a couple of slides I'm going to talk about full-time employees. A full-time equivalent, an FTE, is where you take the number of hours worked in your organization, and your denominator is 2,080 to calculate how many FTEs you had. So if you had a person that worked 2,080 hours, divide by 2,080, you get it to an FTE equivalent of 1. If they worked more than that, you're going to get to a higher factor. And then I'll talk about full-time employees when we talk about large employers. Your FTE wages have to average no more than $50,000, and then you also have to offer a qualified health insurance plan. If you meet those three criteria, you have the capabilities as a small employer to receive a tax credit for the premiums that you paid.